Here again, this is the front, this is the back, this is the fat, these are the little nerve rootlets. You're seeing the abdomen, these are the vessels, the right-sided vessel, probably the vena cava and the aorta towards the left. I mean, that stuff that just, those magnetic waves that's transmitted onto a particular signal gives phenomenal detail. Here you have the posterior spinal muscles. Again, this is anterior, this is posterior. We're looking down. Let's compare. Lateral X-ray, lateral CAT scan, lateral MRI. Okay? Good bony detail. Everything else we see kind of via inference. The electrons have not passed through here, they've been absorbed. Same here. Around, this beam is delivered around an axis. We're getting reasonable detail of the bones. We're seeing the nuances better. We're seeing some of the lineup of the spine. This bone is slightly in front of this, known as the slight listhesis. See, it's not lined up to this forward motion. And the MRI, which given us overall the greatest detail. We're seeing the nerves here, we're seeing fluid, we're seeing fat. We don't have to infer as much, we can directly visualize. Those are three essentially normal spines, and now we can compare what it looks like in some degree of abnormality. Here's a L5S1 degeneration, right? So age of this spine, probably along the lines of 40 to 70, right? I would say maybe younger than 70 in the sense that these discs look pretty well preserved, so it looks like it's an isolated L5S1 degeneration. Take a look at this. CAT scan, degeneration, right? Collapsed disc, degenerated disc. You're seeing the joints very well, and they've got sclerosis, meaning the electron beams are not passing through them because there's increased mineral content, calcium, and that usually speaks of some arthritis to the joint. You're seeing a slight fracture here of L1. So you're getting nice detail, not as real life as the X-ray, but exceptional bony detail. And then we come to the MRI where you're seeing, as mentioned, everything. And look at that degenerative disc here. You're seeing good disc height, good disc height, excellent disc height, and then almost no disc. The disc that is there is black, it's collapsed, and look what's happening to the bone. You see that white character there? That means that the bone is losing the impact of that shock absorber. It's starting to react one to the other, so you're seeing a lot of detail here.
This may be a dumb question, but is there any way to prevent or even regenerate, if you have, say, degenerative discs, if they get smaller, shorter, whatever you want to call it? Is there any way to prevent that or help that if you start, if you catch it early?
That is a great Sunday project, and as soon as you get a little traction on it, I'm ready to help you with it. But obviously, that's the gazillion-dollar question. What we do know, what we cannot even say definitively, like to say, okay, tell people to lose weight so there's less load on their spine. What causes a disc to degenerate is so multifactorial. It's a function of your genetics. It's a function of your weight. It's a function of what you do. It's a function of activity. We know that you're best off being in good physical shape, not so much to prevent the disc from collapsing, but to offload the disc. In other words, these discs are shock absorbers. They're bolstered, they're upheld by the surrounding muscles. So if you've got a good, strong abdomen, 6 or 8 pack, and you've got a very strong spinal musculature, you're going to offload those shock absorbers. Kind of like the chassis can offload the actual shocks themselves. That's probably the best and most realistic thing anybody can tell you to do. Smoking purportedly has some direct effect. Nicotine has some direct toxic effect onto discs as well as bony healing. So on average, smokers versus non-smoking controls do have greater instances of back pain. Again, it could be stress-related, it's a multifactorial issue. But to prevent degenerative disc disease, not an easy problem.
I have a question too, actually. We have a facility that has told us in order to schedule MRIs, they require to have an X-ray done of that body part first. And I know a lot of doctors do that anyway, but I wonder what your opinion on requiring an X-ray first before an MRI would be.
And there's a good reason for that, and part of the reason that companies want that done is, again, for overutilization. If a patient is shoveling snow and then feels they have a sore back, or after playing softball on a Sunday, after not exercising for a while, feels there's a sore back, what's the most likely reason for that? Muscle strain, maybe a disc strain, but you don't need necessarily an MRI for that. Now, therefore, if the patient has, let's say, a week or 2 weeks of complaint, and it's not getting any better, and, you know, an X-ray may be the right choice, because maybe they have a small compression fracture or something like that. An MRI is going to tell you a lot more. But the company, you know, to a certain extent, the reason for that is that they don't want an overutilization. Otherwise, everybody who, you know, sprained their back would get an MRI. If we only have one study to get, it's going to be an MRI. But sometimes you just don't need that degree of complexity. Time factor. How long does an MRI take? The average lumbar spine is over 30 minutes, I would say. It's certainly more than the CAT scan, which is more than the X-ray. So all these things have both a fiscal cost as well as a time index to them.
So with that, most likely the radiologist would review the X-ray report to see if there's maybe something else that could be caught before putting the patient together.
In the real world, most people that have persistent complaint, and perhaps, you know, appropriately so, they're going to get an MRI. That's what's going to happen. You know, and that reason for that, so just, you know, some of what's driving that is medicine. Some of what's driving that is secondary gain. You know, there are people that there are reasons that MRIs are ordered that are kind of beyond everybody's control and cannot necessarily fix the world. You know, the patient, just as a sordid example, a patient, for whatever the reason, is looking to mount litigation. They're going to want an MRI to show, and they're going to want that MRI to show something. You know, now, so an X-ray shows less. So when we look at, frankly, this is almost the first time I've looked at it directly this way. If you want to show something, what study do you have that's going to show you something? It's an MRI. Since it's going to show you more of everything, and you're looking for something, you may as well get that study that can pick out a problem in the disc, that can pick out a problem in the nerve, that can pick out a problem in the muscle. So there's a lot of different things in, you know, on the dark side that are driving the need for some of these studies.
So why don't doctors, I mean, I know that, like, there's not much to be seen from an X-ray comparing it to an MRI. So why aren't doctors, like, pushing for these 1.5 high field, like, or, like, if you have an MRI, like, in a 0.3, it's still better than an X-ray's, like, quality. I mean, or they just assume that maybe, like, if it's sent out to these radiologists...
Let's say you're looking for a spinal curve. The patient comes in and has a sprained back, and they look at them, they're not straight. What's a better study, an AP X-ray or an AP MRI? AP X-ray. AP X-ray, because again, that X-ray is actually showing you the curve in real time versus, you know, we saw that coronal shot on the MRI. I saw a lot of detail, a lot of different things, but it wasn't the bones as they really are. No question, MRI is a better overall study for most applications, but it's just not necessarily, and it's not always the best for everything. Simple fracture. Patient falls, breaks their forearm. What's a better study, X-ray or MRI?
X-ray.
Absolutely. An MRI is going to show you too much data. It's going to show you the bone, then it's going to show at the fracture site like a lot of activity, because those those magnetic fields are picking up the edema and the flow. When all you really want to see is, what do the bones look like? Is it broken, and how much separated they are? So there are cases where you've taken, let's say, MRIs, and I want to give you since you brought it up, let's give you the worst case example. Patient has a fall. Again, we're constructing this case, but this has happened and will happen. Patient has a fall, falls onto their radius, neglects it for a little while, keeps playing, neglects it, ultimately comes to a doctor. doctor's half paying attention, so he says, what he hears is, I have this pain in my arm for about 4 weeks. 4 weeks, wow. Any other medical history? Yeah, well, my a relative, my father had colon cancer at a young age. Oh, colon cancer, we gotta make sure it's not a malignancy. What's he gonna do? He'll get an MRI. What's that MRI gonna show? Edema, activity, patchiness to the bone. Diagnosis? It's a fracture. But it looks like a malignancy. It's just sometimes too much data. You have to know what the right modality is. So if it's a fracture, I want to see an X-ray first so I don't get over confused from all this data. And more than once they've taken simple fractures and diagnosed people and even offered treatment, although I can't recall a case of that, for calling it a malignancy. Okay, so fracture is a bad modality as an initial study with an MRI. You'd much rather have an X-ray.
This is building off TJ's question. So you can spot pretty much anything, right, with the MRI. So like, do rich people get like a full body MRI to spot something at a young age, and then see?
Google concierge medical service or concierge MRIs. If people wanna, there's, you know, every so often you
Then
hear
you could
about
like
some.
spot something and then.
Every so often you hear about some executive that got an MRI just as a screen and he found a small, you know, tumor which he. And you can say to yourself, well, why not do that on everybody? It's an issue of utilization, and it's also going to be an issue of Pandora's box syndrome. Not everything that's out there do you want to know about, should you know about, and is it wise to know about? Okay, what happens if you take an MRI and it shows a benign mass in your head? Benign, what's benign? Now it's on your head. You've got this benign mass, then you're going to want another MRI. Oh, next MRI. Was 0.5 cms last time, now it's 0.55. Now there's a margin of error on every study. Is it really, did it grow or did it not grow? Now you have more things to worry about. Then you get a surgery. That surgery, you get an infection. Now you're on antibiotics. There's always both a fiscal cost, a time cost, and energy cost to every intervention. It goes for life in general, but mammography, this is a big issue. Why not do them more often? Why not use the special scanner? Certain things you don't want to pick up. It's not, you know, there's an art and a science here, and you know, and you put cost into the factor. It's a hard soup to get right. There's no perfect answer for everybody.
Is mammography an X-ray?
Mammography utilizes X-ray, yes.
Doctor, lastly, I just quickly wanted to know diagnosis, because like for us, like here, like usually we come across all these cases and each one has a diagnosis, but then sometimes like the script would just say pain, as compared to like other times, like lumbar spine, you find like an HNP. So like, I mean, what goes in there? If I say pain, what are they looking at in that MRI? Like,
if the request says pain,
yeah,
right? Could be just pain. A lot of times that could just be a function of whoever filled out the MRI slip. Could be the doctor, could be the office worker, and they got to fill out something, so they put down pain. Could be pain in the back, could be pain in the leg, could be rule out sciatica. You know, pain is a symptom, so they'll put it down. So it's hard to say what could be just simple back pain, it could be pain that's going down the leg. It's hard to say what's driving the study.
So I guess it's an MRI image, like the report is coming out and it's giving you, is it going to be standard, like regardless whether it's saying pain or whether it's saying the rotator cuff?
The report?
Yeah. Are they coming out with like a basic information, like we took a picture and this all depends that we're seeing?
Okay,
or
so we'll talk about that at the end here, but basically there's always going to be two components to this MRI or the X or whatever it is. There's going to be the technical component, the study, and then there's going to be the interpretation. The radiologist has limited clinical data, sometimes zero, sometimes they don't even get a reason, right? They want a reason, but there is an advantage to not having a great clinical knowledge of the patient. There is an advantage to that. Anybody could think what the advantage is?
Double blind.
Yeah, there's a lack of bias. If I say to you, rule out sciatica, you're tunnel vision to a degree, not looking for a disc herniation, you may miss a spinal tumor. You know, I mean, I know a friend of mine who's a very well-known spine surgeon, he does a lot of spine cases, you know, he was brought to suit because he saw a spinal x-ray, showed a fracture. Meanwhile, patient, even on x-ray, had an enormous calcific uterus, like 20 pounds. Now, you'll take a look at that x-ray and you'll say, how did he miss that? He even joked about it when the lawyer showed it to me. He's like, I'm a doctor, she really needs sound here. But the point is, when you're looking for a fracture, you can tunnel vision. So there is a certain advantage to them, to the radiologist being blinded. So therefore, they're obligated to report on everything they see, the bone, the soft tissue, the fatty masses, the nerves, to the best of their ability. Now, a little bit of history helps, because then it tells them, if you're worried about a radiculopathy or a sciatica, then you're really looking at those discs a little bit more. But ultimately, and I think that for my radiology rotations, they'll tell the residents, first look at the film without looking at the indication. So you have zero bias. Then go back and look at what the indication is, so therefore you can center in on it. We spoke about costs a little bit, and I'll try and wrap this up. What is the cost of an X-ray of the lumbar spine versus a CAT scan of the lumbar spine versus an MRI? That's a hard question, and that's part of what brings us to 88 Pine Street, and somehow we're attempting to introduce quality measures and cost measures to what we're doing. That's what Spreemo stands for. So it's even a very hard question to answer. So I went online looking for just some rough estimation of what we can transmit. So in one particular Missouri locality, as of January 15th, the outpatient reimbursement for a lumbar something was $27.77. Was that a CAT scan, an MRI, or an X-ray?
X-ray.
That's an X-ray, right? Now, we spoke about the components. There's always at least two components to every radiologic study. There's the technical component, the fact that that patient went into a modality, X-ray, CAT scan, MRI, and there's the image, the pictures, the films, CDs that are generated, technical component. Then there's the professional component or the interpretation. So this number here, which is obviously quite low, my parking today is going to cost more, for sure, is just a technical component, on top of which is their professional component. So we just want to go through orders of magnitude here. One of these studies has a reimbursement for a lumbar something, the technical component, not the professional interpretation, of $143. Is that an MRI or a CAT scan? Yes, it's a CAT scan. And lastly, an average reimbursement for a lumbar MRI of $273.63. So obviously, if you go to any facility here as an outpatient reimbursement, your numbers are going to be higher. But the orders of magnitude are probably correct. So we're talking X-ray versus MRI 10 times, CAT scan versus MRI 1.4x, something like that, right? So there's a cost, and there's a, as we said, that cost comes in multiple factors, one of which is actual dollars. And we're here as this organization is attempting to introduce measures to make things more efficient, as well as cost and quality. So we just want to point out there's always that technical component, the professional component. And I've rigged this a little bit. I've rigged it a little bit, but one of these studies is a high quality study and one is a lesser high quality. And you can see there's a difference. If you're a physician, if you're in a carrier and you're looking to make a determination as to what's what, which of these two studies you want to do. Now, by the way, I didn't purposefully rig it. I tried to Google bad lumbar image MRI, and this is, what kind of, I had to fish for it. Nobody's really promoting bad images. They like to show you something like this, right? And that quality of the image, typically, there are other things, but I just want to leave you with the following. The quality of that image is usually a function of the size of the magnet, the Tesla unit, right? Nikolai Tesla. Typical standard, gold standard is 1.5. The Super Daddy Rolls Royce is the 3.0. But also, you can get very good images nowadays just by beefing up the software and the programming. So there's some 1.2, 1.3, or 1.5 units that come close to those higher end 3 units just by beefing up the programming and the software. Okay, here's those last 30 seconds, the quiz. What's the best for real body appearance of bones? X-rays, CAT scans, MRI.
X-ray.
X-ray. Best for bone nuances.
CAT scans.
Best for soft tissues. MRI. Best for nerves. MRI. MRI, with a CT myelogram, we can come close to an MRI. And what is the advantage of a CT myelogram over an MRI? It gives you, since it's putting dye in, and we can take multiple shots at that time, it can give you kind of a real-time existence. So there is some advantage to that. What has the least radiation? X-rays, CAT scans, MRI. MRI. What has the most radiation? What has no radiation? What's the cheapest study?
X-ray.
What's the most expensive? What's the best company to be at now?
MRI.
You don't do it.
Oh, you did film it? I didn't know that.
No,
You did film it? That's fabulous.
We didn't want to let you